we've been in the business of MACRA compliance before it was MACRA, back when it was PQRS. It's probably been 7 or 8 years since we've been doing this. And we frequently hear the same kind of negative feedback and perspective, and it deserves it deserves some comment on our side. We see both sides of it. Look, we're on monthly phone calls with CMS. We recognize the difficulty that they have. We also sell a product to the customers that helps makes this process easier, right? So we live in the middle of these two different worlds. And we hear a lot of negative feedback, primarily from the physician anesthesiologists. The CRNAs tend to be more accepting, and just it's another documentation issue, and they tend to be more accepting of the MACRA policy than the physician anesthesiologist. So I felt like it was a good opportunity to just spend 4 or 5 minutes and talk about what the MACRA program is, but not the technicalities of it, but perhaps a better way of framing it, right? So the typical way people see it, or I would say, if you're negative towards the whole MACRA process, we hear that this is a government conspiracy. It's the bureaucrats don't know anything. Nobody understands how good I am, or the job that I actually do. What are some other this is all a ploy just to reduce our payments and limit the budget, which couldn't be further from the truth, because it's a budget neutral program. It's just a redistribution of the income from the poor performers to the high performers. And in fact, CMS is throwing in an extra 500 million per year. So if anything, it's a bonus. It's extra money that CMS is putting on the table to do this. So what I want to try to do is offer some alternative frameworks to look at it, so that it's not such a negative, visceral response when you hear the word MACRA. The truth is, most can just adopt out of it and say, no, I'm not going to qualify, and I don't want to participate. But I will tell you, I would highly recommend. I would tell you that's the wrong approach. And so perhaps these, let's go 2 or 3 different alternative approaches to frame it. The first one I'd say is that the public wants quality. And the problem is they don't know what that means. They don't know what it is. And so they turn to the government and they say, well, what is, we're only going to pay for quality healthcare. And we want to know, of all of these physicians in front of us, or healthcare providers, who's more quality than the others. And it creates this really interesting issue, because you can't say that quality doesn't matter. You also can't say that everybody's quality, right? You lose the meaning of the definition excellent, right? So you want to know who is excellent. Well, if we're all the same, then you've just destroyed like what the word excellent means. Now everyone's average, which is not bad, but people have in their mind, we want quality, right? And so once you accept that that's what the public wants, then you recognize that whatever it is, it needs to have certain things, certain adjectives. It has to be measurable, right? It has to be objective. You can't just have an opinion survey of how well did you think you did today. Like, that wouldn't go anywhere. And I think perhaps the most confusing part of the whole MACRA program is that it has to be different among providers. And it gets back to this definition of excellence. If you just say, well, I want to measure on-time antibiotics, or I want to measure just the patient's temperature in the recovery room, or I want to measure how often you did handoff protocol use, that's fine. The problem with that is everyone's doing it. And so if you're trying to define quality, and there's this essence of who's exceptional or who's excellent, or how does a given measure's outcome distribute across a group of providers, then you recognize it can't be easy for everybody. It has to be something that will distribute. Not everyone can be perfect. I tell you, the CMS every year reaches out to special society groups, like the ASA. They reach out to individual providers, so it's open to anyone who wants to recommend a new measure. And it happens every year. And every year, the bane of our existence is that we have to, every year, every 12 months, these rules get recertified. And so new rules come up, and then new measures come up, and then old measures that everyone did super well on get retired and they go away. And so it's a constantly churning process. And I will tell you that it is very difficult to define good measures. When you say that they have to be something that you can actually measure, it's not, it's something, that can be objectively measured. It's not an opinion. And then it has to distribute across a group of providers. Not everyone can be perfect at it. It's, especially in the world of anesthesia, it becomes quite the challenge. So that's one way, is that the public insists on quality. And so once you accept that, then it leaves you with these conclusions that, okay, how am I going to participate in that world? I can't just dismiss that public need. Another way of looking at it is taking that same sentiment maybe a step further. And once you've accepted that you need a quality program, once you've accepted that either it's because the public wants it or it's because the hospital certification bodies, for example, the Joint Commission wants it, maybe it's just that your hospital wants it, maybe it's whatever it might be. You just need, once you accept the fact that I have to have a quality program, regardless of the reasons, then I would say you want it to be meaningful, and why not use the program that the CMS is going to subsidize your costs, right? So once you accept, I need a quality program, look, it's going to cost money. You're going to have to collect more data. You're going to have to analyze more data. You're going to have to report on more data. That's going to take time. And if you don't want to use software and you just want to use an Excel spreadsheet or a sheet of paper, then it's going to take a lot of someone's time. If you want to adopt an electronic solution, then it's going to come at a cost. Thankfully, CMS is giving bonuses for folks that are exceptional performers. And in the world of anesthesia, we all can become exceptional performers. We see it year in, year out. People do fantastic on their composite performance scores. And so those bonuses go up every year. And this year, it's somewhere around 6%, 6% is the realistic bonus that we should see. And that should more than offset the costs of the financial costs of any data collection for a quality program. So it's another way to look at it. Is look, number one, the public wants quality. Number two, once I recognize I need a quality program, I might as well turn to CMS and let them pay for it. Maybe I can make some extra money on it as an extra ROI, but it should very easily break even for it. So why go off the reservation and develop your own unique quality program rather than not jump in line and follow the MACRA program? And then I would probably the biggest reason that we see people that actually adopt our solutions or actively looking in the marketplace is because they've recognized that their competition is doing it. And so regardless if you want to disregard the need for quality, you want to disregard the fact that the CMS is going to help pay for it, um, there is a competitive need. Certainly the large national anesthesia groups are all collecting quality data. They all have infrastructure in place for comparative regular reporting each month, each quarter across all of the members of their group. And the hospitals respond to that in a positive way. When they see your culture is actually one of safety and that's backed up by expenses and, like I said, infrastructure and policies and processes in place to measure these things, it's a head turner. And we see that time and time again. So if you want to protect your existing market share, if you're interested in growing your existing market share into a bigger space, being able to lead with this is how we handle quality, this is how we can help report and add transparency to you all at the hospital level, time and again, it just turns heads. That is a differentiator. It can't just be that we wake up all of our patients and everybody likes our service and our surgeons like us. All of that helps, there's no doubt. So there's lots of different ways to differentiate yourself. I'm not saying this is the only way, but it is a big head turner and an easy way that is realistic and can help differentiate you from the competition in the marketplace. So in conclusion, MACRA is here to stay. It's time to move on from the government is ridiculous and all these political perspectives or framings of the issue, which I don't think are constructive. And they're going to leave you stagnant in a time when everyone else in the marketplace is moving in that direction. And soon you will be isolated and be on your own and simply not have the infrastructure in place to report on very simple things like these different MACRA quality measures. So it's a program. It's not going to go away.